on our Twitter feed and on our website. I am now going to hand you over to Professor Clarke, but just one thing before I do. We need people to join LIDC if we are to carry on doing the work that we do. We will put the joining link in our chat here. Membership is free if you are in any of our member institutions. As if you've ever studied or worked in an LIDC member organisation, your membership will be covered. And it's also possible for individuals to join us. We encourage people to live tweet. So again, I will put the relevant Twitter handles in the chat. And there will be time for discussion after the presentations today. Professor Clarke will shortly introduce you to the speakers. We are very honoured to have Professor Clarke with us today. Many of you will have heard her over the past week or so, talking to a number of news organisations to discuss the recent and most welcome news on the malaria vaccine. Sian Clarke co-directs the LSHTM Malaria Centre, which is a multidisciplinary cross-faculty network of over 200 malaria researchers based at the LSHTM. Her research focuses on epidemiology, intervention trials and global health, with an emphasis on applied research to inform malaria control. We're very grateful that she has been able to make time in her busy schedule to moderate this event on our behalf. And I have great pleasure in now handing you over to her to introduce the speakers. Thank you.
Thank you very much, Shireen. Today, actually, I'm wearing my One Health hat as the co-director of the MSc One Health, a joint MSc course between the London School of Hygiene and Tropical Medicine and the Royal Veterinary College. And we are joined by this year's cohort of students. And this afternoon, we have two speakers. We will, first of all, be hearing from Dr. Osman Dar, who is a global health physician based at Chatham House. Chatham House, for those of you who are unfamiliar with the organisation, is a world-leading independent policy institute with a global mission to help governments and societies adapt to change and build a sustainably secure, prosperous and just world. Chatham House aims to provide thought leadership on key issues, one of which is antimicrobial resistance, amongst many others, to broker complex or difficult policy discussions, to share insights and identify solutions. And Dr. Dar has many responsibilities at Chatham House. But since May of this year, he has been a member and working group co-chair of the UN-sponsored One Health high-level expert panel advising WHO, OIE, FAO and UNEP on their global One Health focused strategies and activities. And I have pleasure in handing you over to Dr. Dar to take us through some of his important work in this area.
Thanks very much, Professor Clarke, and I'm happy to be here with all of you. It's an honor and a privilege. I'm going to try and speak a little bit about antimicrobial resistance, but what I'm going to go into, I'm going to come at it from the sort of Chatham House angle. So what we're going to talk about is the politics and policy around framing AMR control in a global and a One Health context. I'll just try and share my screen. Let's see, which screen is it? It's this one. This one, I think. Can you guys see the slide deck?
We can only see you at the moment.
Okay.
Okay, no, it's coming through now.
So just let me know.
Yeah, great. Thank you.
Okay, so I've got a lot of slides, but I'm going to rattle through them quite quickly and try and stick to time. So as I was saying, we're going to talk a little about framing AMR control in a global and One Health context. You're all sort of familiar with the One Health concept, and that's sort of why you're here. But I think it embodies two quite distinct concepts within the approach. One is that humans, animals, and the ecosystems within which they live are highly interdependent, and that the approach, and then the second concept is that the approach solicits or integrates collaboration, cooperation, coordination across multiple sectors and at all different levels of society. So it involves the public sector, involves the private sector, non-profits, academics, and from the community level all the way up to the global level. So those two sort of concepts are embodied within the approach. And it's important for us to be sort of cognizant of all of that. What I'm going to talk a little bit about during this talk is drivers and interventions around AMR. I'm not going to focus too much on that because from a Chatham House perspective, it's more about the politics and the policy framing. So we're going to talk a little bit about globalization and how we've had the rise in attention to AMR, how it's being framed across different settings, the push for a global homogenized response and why this might not work, and how the issue might better be framed in low and middle income country settings. So from the outset, Chatham House at least has been involved in quite a few of the sort of, I'd say, instrumental work around getting AMR up the global policy agenda in the sort of 2013 onwards, when it really started to gain traction, both in science and in wider society. And part of what we were, and the strategy at the time, at least the strategy from the UK perspective, was two-pronged. One was to properly explore the evidence base, the science and the evidence base, and really try to make the case scientifically and evidentially. But the second was a second track around socio-political engagement and advocacy, and making the economic argument around it. And this stems from experience with how climate change was brought to the fore as a global issue. The Stern review on the economic impacts of climate change was seen to be instrumental in getting it up the policy agenda. And in terms of drivers, one of the papers, so we were involved in this Lancet series on AMR. One of the papers focused very much on the drivers, and this slide sort of outlines at the time what the evidence base was around different drivers. And for me, it was particularly interesting to see that and especially from a low middle income country perspective, that suboptimal use and dosing, and including the use of substandard antimicrobials, both in the human and animal sector, was quite an important factor. But moving on from that, around the interventions, the real key was to improve control was around two areas. One was infection prevention and reducing the need for antimicrobials in the first place, and the other was fostering more responsible use, and us as humans being better stewards of the antimicrobial tools that we have in our armory for dealing with infections and disease. And the evidence base around both has been is sort of divided into different sections. On the demand side, the most effective interventions have actually been around improving access to clean water and sanitation, improving infection prevention and control systems in animal systems as well as in human societies. But very little of the investment has gone into this side. And you have to ask the question, why is that, right? Even after AMR control has become a global issue, there's very little that's being put into sort of wash systems, into vaccination, and into improving infection prevention and control. So why is that? And we'll get into some of that as we go through the slides. On the supply side, governance and regulations have been poorly developed and inadequately implemented across human, animal, and the environment. And of course, the low access to diagnostics has been a continuous issue. Similarly, across the world, we find weak medical and veterinary education and a proliferation of informal and untrained providers. And that's a real black box. The size of the private sector when it comes to the proliferation and inappropriate use of antimicrobials. A lot of the data we get is obviously from public sector institutions and from governments, but often in most countries, it's the private sector where a lot of the sales and injudicious use is promulgated. Just in terms of the issue itself, the associations, at least from a One Health perspective, have become increasingly clear when, for example, in Denmark they stopped using macrolides. In pigs, you saw immediate reductions in resistance levels, and likewise, we're in Europe. In Europe, we continue to see quinolone use in poultry, and so you still have high levels of quinolone resistance. And whereas macrolides have been reduced, you've got low levels of resistance in the poultry sector. And it's interesting that the links between, I mean, we would like in our ideal world to be basing our decisions on science and evidence, but the evidence around that shows that we don't tend to do that. We, by and large, often a huge factor, or sometimes arguably the biggest factor, is actually politics and economics, and so that's why that strand of addressing the issue is very important. So we don't import poultry into Europe from the United States because they wash it in chlorine, but in the United States, for example, they've banned quinolone use in poultry for many years, since 2005. But we haven't done that yet in Europe. So it's interesting that poultry imports are banned from the United States. Of course, there's continuing use in the environment as well, and we sometimes underestimate the amount of antibiotics that are being used in the environmental sector, in the agriculture sector. A very good example is recently under the Trump administration in the US, the Environmental Protection Agency approved the use of tetracyclines for citrus greening, which is a disease that affects citrus fruit. And in Florida alone, that meant that they authorized the spraying of about 1 million kilos of streptomycin, just over hundreds of thousands of acres of citrus plantations, and that accounts for probably 4 times as much oxytetracycline and 36 times as much as streptomycin as is used in the US in the human sector. So it easily dwarfs the amounts that are being used in the human sector, and all that is under an economic imperative, right? So it's quite interesting to see that just how much of an influence economics has over decision making, policy making at the highest levels. In terms of, I just wanted to raise the point around the counterfeits and substandards as well. And with a lot of the work's been done around antimalarials in Southeast Asia. Studies that were done across the 2000s have shown that sometimes over 50% of artesunate samples were counterfeit. They did recent studies in Nigeria in neonatal intensive care units, and a lot of the antibiotics, up to 70% in some series, were counterfeit or substandard antibiotics being used in the neonatal sector. So just imagine if that was the situation in Europe or in the developed world, that would be scandalous. Nobody would really be talking about resistance. They'd be talking about getting our systems in order so that we have quality assured medicines first. But that's again a different part of the debate, and it comes to how we frame these debates. So in terms of the evidence base, responsible use and effective infection prevention control interventions can reduce the demand and need for antimicrobials. In animal environmental sectors, IPC, infection prevention control and surveillance programs, are currently chronically underfunded and require significant uplift. For low middle-income countries in particular, there needs to be an additional focus to improve monitoring of drug quality and marketing to sort of curb the proliferation of counterfeit and substandard drugs. In terms of the economics, the World Bank estimates that the funding needed for 60 low-income countries and 79 middle-income countries, so almost 140 countries, to bring their animal infection prevention and control standards and systems up to OIE and WHO standards, ranges from about 1.9 billion US dollars to about 3.5 billion US dollars. So that means, and remember that this doesn't just help control antimicrobial resistance, it also helps prevent spillover and spillover events and zoonotic spillover in particular. So in terms of preventing, the next pandemic or the next zoonotic spillover, that they're important interventions. And if you think about the cost of the COVID-19 pandemic, that obviously dwarfs anything that the costs in investing in these kinds of IPC systems would entail. So that's important to remember. So what about the globalization and the rise in attention to AMR? How did that all happen? A lot of us have known about anti-malarial resistance for many years, for decades, for 3 or 4 decades. In fact, more than that, since the 50s and 60s, we've been having increasing chloroquine resistance. So how come it's never been a global issue? Failure rates, even with ACT therapies, have been increasing, but nobody really thought, hey, you know what, AMR should be a global issue. And why was that? And I think it's important for us to sort of be reflecting on that. These are obviously diseases of the tropics. These are diseases that don't affect high-income country populations as much. So perhaps, that's a major part of the reason why AMR was not a global issue. The same with HIV anti-retroviral resistance. We've been seeing increasing levels of resistance across the world, and in particular in low and middle income country settings. The same picture was there with the tuberculosis and the rise of MDR-TB. But again, the issue never really gained the kind of traction it has in the last 6 or 7 years. It's only when we sort of started seeing, massive increases in the use of antibiotics, in particular, almost as a sticking plaster to counter the rise of infectious diseases, being spurred by some of those issues we discussed previously: poor water and sanitation, poor urban planning, poor housing, poor nutrition, and the rise of sort of resistance rates in tertiary care facilities, so in hospital settings and secondary care and primary care settings in high income countries, that people really started to take notice. And I think that's really important for us to reflect on when we then want to have a global system for antimicrobial, for curbing and controlling antimicrobial resistance. So I think, yeah, in terms of how those efforts are then sustained, it has huge implications, right? And I think, part of the framing was this socio-political engagement, and a big crucial factor within that was the launch of the O'Neill report. So as I was saying to you earlier, that one stream of work was around the economic and socio-political imperatives around antimicrobial resistance. And in 2014, the world-renowned economist Jim O'Neill was asked to lead a review of the economic impacts of antimicrobial resistance, and we had the O'Neill report. And that had a number of really headline sort of statements within it. And it's really interesting to look at the actual science around that, because presumably this is a group of mostly scientists. And many of you will have heard the figure, 10 million deaths by 2050 or $100 trillion effect on world GDP. I mean, most of us won't even be able to, imagine what $100 trillion looks like. And those are the headline figures that people have taken away from that O'Neill report. It has a lot of wonderful information on that is scientifically sound within it, but these headline figures, I'd argue, if you look at the actual methodology used to generate them, are highly suspect. So just around the 10 million deaths from AMR by 2050, that was done by the RAND Corporation, which is, it's a big global US consultancy, and they used KPMG as well to develop some of those estimates. And the way they did that was they modeled that if every infection, bacterial infection, and including malaria, HIV, TB, the big killers, were 100% resistant around the world, and and people were treated, then how many deaths would you have? And that's how they sort of worked it out. So they worked it out based on this hypothetical model that every infection, common bacterial infection, and HIV, TB, malaria, the big killers, were all 100% resistant. And I mean, you know, scientifically, is that something sound given the trajectory we're on? I'd argue not. And so that's how they generated. But I mean, it had the desired effect. It was meant to raise the issue and provide some headlines, and that's what it did. But unfortunately, even within the scientific community, we all tend to use those figures whenever we write a paper or anything else on AMR. So it's just something to be aware of. On the UK National Risk Register, it was prioritized and it made it onto the risk register alongside things like pandemic influenza. But it did cause a distortion in how resource allocation was done. So it's not to say that AMR isn't, you know, a globally important issue. Yes, it is, but because there was this overwhelming focus on AMR, other issues that were also on the risk register, so things like emerging zoonoses and pandemics, for example, up here at the top, got downgraded, and look where we are now. We've had an emerging infection and a zoonotic spillover. And a global pandemic. So a lot of people at the time were arguing that, you know, are we doing the resource allocation right? So if you look at the Ross Fund, which was sort of £1 billion, almost £1 billion worth of development funding for health security, global health security issues, the vast majority of it went to antimicrobial resistance, and a very tiny proportion, probably I'd say between 1% and 3%, went to emerging infections or pandemic control issues. So you know, that kind of decision making at the top does make a difference. And it's not to say that, you know, AMR isn't important, but we probably got the balance wrong in where the size of the investment was put, and where also along the spectrum of AMR control issues the investment was put in. So a lot of the investment was put into surveillance and detection and laboratory systems, and very little has been put into the upstream interventions that tend to be most effective. So water and sanitation programs, nutrition programs, vaccination programs. Very little has been put into things that actually reduced resistance. And really, it was a convergence of these issues around health security, as well as antimicrobial resistance. And I think Lindsay's going to talk to you a little bit about the joint external evaluation, how that works. But essentially, because there was this huge push around health security issues, which mean that global health ends up being prioritized and framed through this security lens, a lot of the investment ended up going into things which were primarily of interest to high-income countries in terms of them protecting their own populations, and less in terms of the priorities of low and middle-income countries, which meant, in a sense, that while there was that donor funding available, you know, programs would be sustained in low and middle-income country settings, but as soon as that donor funding dries up, there's huge question marks over the sustainability of a lot of the interventions that are put in, including those around antimicrobial resistance. And if you look at, in fact, the scorecard or the monitoring framework within the international health regulations around AMR, it's primarily surveillance of infections caused by AMR pathogens and healthcare associated infections, prevention and control programs. And that's what I was sort of saying to you, that a lot of it is framed around what the health security risks or needs are of high income settings. And it's interesting that when we expound or talk about the risks, we speak about antimicrobial resistance, but whenever there's interventions that are funded globally, we're talking about only antibiotic resistance. So, you know, everything, malaria, TB, HIV, those sort of go out the window. A lot of the animal infections go out the window, and there's a very narrow focus on antibiotic resistance, particularly of infections and bugs and pathogens that are, you know, health security challenges within high income settings. And I think that's where we've sort of really missed a trick as a global AMR community in how the issue should be framed, especially in low and middle income country settings. And I think I'd just like to sort of end on that. How do we sustain interest in AMR control in low and middle income country settings? Firstly, should it be framed as a security issue, a development issue, or both? That's the question. My view is that it should be framed as a sustainable access to effective antimicrobials and pesticides, rather than just focusing on AMR alone. AMR is resistance is a physiological, it's a natural phenomena that's always there. But the issue is whether or not communities and populations have access to an effective antimicrobial, and then that includes looking at issues around access, but also around quality assurance and whether or not they're substandard or counterfeit. We need to invest more in the hygiene, water, and sanitation programs and IPC. Obviously, we need to harmonize and coordinate donor and development assistance against what are nationally and regionally determined priorities, rather than those determined by donors and more globally. And the nationally identified priority lists of antimicrobials and pesticides used must be monitored for relevant pathogen and vector resistance profiles. In terms of surveillance, it needs to be nestled across human, animal, and the environment. And there's been very little put into environmental surveillance systems, and more needs to be done in that space. And then finally, as I was sort of saying, surveillance of counterfeit and substandard antimicrobials and access to quality assured diagnostics should be part of the health security strategy. In terms of what we're doing at OLEP, I think that's the kind of thing that we're really trying to push. So we're trying to through the One Health high-level expert panel support the global action plan on AMR by perhaps picking up on issues that aren't being more wholesomely addressed or more holistically addressed. And I think this comes back to sort of what One Health really is and what the underlying principles of One Health are. And we've sort of defined or understood them as the principle sort of highlighted in bold here. So equity between sectors and disciplines, socio-political parity, so that all people are equal and have a deserving of equal rights, and including engagement of communities and sort of marginalized voices within the prioritization process in particular, that we're seeking to sort of achieve this socio-ecological equilibrium with optimal health outcomes for humans, animals, and the environment, and acknowledging that non-human living species have an intrinsic right to live and thrive in of themselves, apart from just being viewed through that sort of anthropocentric human lens. That as humans, we have a stewardship function over the sort of the whole planet, and that we have responsibilities to future generations as well, and that transdisciplinarity is sort of embedded within all of this. And so just in terms of that equity space, I think it's really important that the prioritization and the way we do the resource allocation around AMR control programs includes all those voices, especially voices from low and middle income country settings, where the issues are more around access to an effective antimicrobial than the actual resistance rates of very specific bacterial pathogens. So I'll just end with this. But thank you everyone for, I know I went over a little bit, but apologies for that, but thank you for listening.
Thank you very much, Dr. Dar. And you raised many issues, and I'm sure it's going to stimulate many questions. So before I hand over to our next speaker, just want to remind everyone that there will be time for discussion later. So please go ahead, put any comments or queries that you have in the Q&A box at the bottom of your screen, and then we will be collating those questions to our two speakers this afternoon. So our second speaker is Dr. Lindsay Elton. Dr. Lindsay Elton is a postdoctoral researcher at the Centre for Clinical Microbiology at the University College London. And she's part of the Pandora Infectious Disease Net consortia, where she focuses on One Health, laboratory capacity development, antimicrobial resistance, and science communication. So I'm sure we all agree that all good policy discussions should be underpinned by sound science and responsible communication. And at this point, I'll hand over to Lindsay to introduce us to some of her scientific work.
Thank you, Sian. I will share my screen. Can everybody see that in full mode?
Now you can still see the slide. Oh yeah, perfect.
Oh, bit of a delay, clearly. So I just want to echo what Osman, Dr. Dar said. Thank you for inviting me, and I hope you find this interesting. So I'm going to talk a little bit about zoonotic diseases and sort of their place within One Health, and also talk a little bit about how prepared Africa is for sort of tackling zoonotic diseases based on a study that we did looking into the joint external evaluations, as Osman mentioned. So as I say, I work for the Centre for Clinical Microbiology, and also alongside Osman, I work for Pandora. So what we're going to look at today is I'm going to give a sort of a brief overview of zoonoses and what they are, and a couple of definitions, because I think sometimes they get a bit confused. I'm also going to look through how we can use those joint external evaluations to analyse any country's preparedness for zoonotic diseases, and then specifically hone in on Africa and sub-Saharan Africa to look at how well prepared they are for zoonotic diseases based on their joint external evaluation scores. So to begin with, we will look at zoonotic diseases. So zoonotic diseases are diseases that can be transmitted between humans and animals. And it's thought that roughly about somewhere between 60 and 75% of all emerging diseases that affect humans have a zoonotic origin, and COVID-19 is a potential point in case. Zoonotic diseases can be either emerging, so things like Ebola, that we're sort of coming to grips with relatively recently, or they can be what's classed as neglected. So that's things like rabies and brucellosis, which we've been living with as a sort of a society for hundreds and if not thousands of years. So they're not just sort of things that are only just occurring to us now. They've been things that we've been living with for centuries, and still yet to kind of deal with properly, as you'll see later on in the slides. The burden tends to be on lower middle income countries rather than high income countries, mainly because of the strong reliance on livestock, especially sort of for individual people and families, and also generally a less stable healthcare infrastructure to sort of deal with that, so surveillance and actually treating these diseases. So it's important, obviously, not only for health of animals, but also as an economic kind of cost as well, that we need to kind of look out for, treat, prevent, control zoonotic diseases, as I say, both for the welfare of animals and also as an economic kind of thing, and also health for humans as well. And the best way that we can do this is through this One Health strategy. So we need to include veterinarians, we need to include clinicians, the environmental kind of specialists, and also engage with policymakers and government to make sure that what we sort of find in terms of science is properly implemented, as Osman pointed out. So I'll just go through a few definitions with you. So a zoonosis is an infection which is naturally transmissible from animals to humans, so in sort of one direction, and they have an animal reservoir. So that's when a disease sort of mainly lives within animals, but an animal can either transmit or it can be transmitted to humans. So an example of this is anthrax or rabies. Rabies, obviously, as everybody knows, generally survives within dogs. A dog will bite a human and they can get rabies, but humans, unless I suppose a human bites another human who has rabies, then yeah, but generally it is an animal to human transmission pattern. And then in the opposite direction, you have zooanthropognosis, or a reverse zoonosis, which is the other way around, so from humans to animals with a human reservoir. And some examples of these include methicillin-resistant Staphylococcus aureus and the worm Ascaris lumbricoides. So generally they are within humans, but they can be transmitted to animals. We also, as I touched on earlier, have emerging infectious diseases. So these are classified as a new disease that affects a population for the first time, or an existing disease that is spreading for whatever reason very rapidly, either geographically or sort of affecting an increasing number of people. So these are not necessarily zoonotic in origin, but as I said, roughly 60–70% appear to be. And examples or recent examples of these include chikungunya and COVID-19, which I'm sure you're all aware of. We also have re-emerging infectious diseases. So again, not necessarily just zoonotic in origin, but these are diseases that have reappeared rather after a significant decline. So there are multiple reasons for this kind of thing. The breakdown of the public health measures that have been put in place to keep it sort of controlled. So for instance, a government may think, right, well, we've got this under control. We don't need to worry too much about this anymore. We've got other things, other priorities, and then that sort of starts to creep back up again. Or it might be that there are new sort of strains that have appeared and now are affecting people, whereas they didn't before. And an example of this is plague. So obviously we all know the Black Death occurred many centuries ago, but actually now we're seeing pockets of plague popping up, especially, for instance, in Madagascar and the DRC. We all know that zoonotic diseases are global. COVID-19 is a very good example of that. But it's actually really difficult to quantify or geographically place a zoonotic disease or any, as they have quite complex life cycles generally and multiple hosts, which makes it very difficult to kind of identify them or create diagnostic tests for them. They can often go underreported or not reported at all due to a lack of surveillance. If the healthcare infrastructure is not necessarily particularly strong, then surveillance is often one of those things that kind of gets missed out. So surveillance is when you are actively looking for something. So you might be actively looking in all samples for antimicrobial resistance genes, or you might be actively going out into the environment, sampling mice, for instance, for Lassa fever. But obviously that costs quite a lot of money. And so if your healthcare system is already very burdened, then it's going to be really difficult to do that surveillance and identify these things before potentially they become an issue. They can often survive for really long periods of time without even affecting humans. So either before they kind of become emerging diseases or having been a disease. So again, plague is a really good example. Plague has a sylvatic lifestyle, so actually life cycle. So it lives within rodents and their fleas, and actually, unless humans kind of go and encroach on the environment or they encroach on our environment, plague is quite happy and doesn't need humans at all to keep it going. So this is the problem with sort of climate change and encroaching, and this is why it's a One Health problem, is because we're kind of coming into contact with zoonotic diseases that might not even really be a problem otherwise. Here we've just got a map from this paper that you can see the reference for, and it's kind of like a heat map of mammals and the amount of zoonotic diseases that mammals in each of these kind of squares you can see contain. So you can see on the right hand side the sort of the heat bar. So purple, red are the high number of mammals that have or could potentially transmit zoonotic diseases. And you can see that we've got three sort of hotspots. So South America and Africa, you think might be quite obvious ones, but actually what surprised me was actually Europe is one of the hotspots for the number of mammals that could potentially transmit zoonotic diseases, and the diseases that they actually carry can be classed as zoonotic. And this study kind of covered well over 5,000 wild mammal species from 27 different orders. And they found that rodents were actually one of the worst offenders for potential transmission. So now we know a little bit about zoonotic diseases. So how can we actually analyze how well prepared a country might be to kind of tackle that. So do they have surveillance, that kind of thing? And Osman touched upon this earlier, so I'm going to introduce a little bit more about the WHO's joint external evaluations. So they are open access, so they're all online. You can access them on the WHO's website. They are voluntary and they're collaborative, and they assess an individual country's ability to deal with a number of different public health risks. They're also standardized, so every country will answer the same questions, and these are provided within this toolkit. And so it's kind of like a questionnaire that they fill in. And because they fill them in, but then actually an expert team will go to the country and sort of corroborate that what they say exists actually does exist. They're quite realistic. So as I say, the country themselves will go out, do the research, identify what they actually have, but then that will be backed up by an expert team who go in and sort of check that. And so each of the different indicators have a score out of 5, and I'll go through and explain that now. So within the joint external evaluation form, there are 4 different sort of categories: prevent, detect, respond, and other. And within each of those 4 categories, you've got these sort of subcategories: antimicrobial resistance, zoonoses, etc., etc. And then within each of those subcategories, you've got another sort of subcategory. So within zoonoses, there are 3 different ones. So zoonotic disease surveillance, veterinary workforce, and how many people sort of exist within that, within a country, and then the zoonotic disease response to outbreaks. And then within each one of those, you have these sort of indicator questions. So for instance, does a country have a One Health national action plan for zoonotic diseases? So has this been confirmed with the Ministry of Health, the Ministry of Agriculture, the Ministry for Environment, that kind of thing? And so each of these questions will have been scored from 1 to 5. So 1 is no capacity, and I think you saw earlier on Osman's presentation, no capacity basically means this country just hasn't really even considered this yet, all the way through to sustainable capacity, which means, yes, this country has whatever this is. So they have a national action plan, for instance. It has been approved by each of the different ministries that need to be involved. And actually it's sustainable in that it's so well implemented that actually this country is a really good example, and that example could be used by other countries to kind of build up their own version of that. So the countries will be scored somewhere between 1 to 5. So that's kind of how joint external evaluations work. So I'll take you through what we did when we looked at the scores for sub-Saharan Africa. So you can see here, this is our paper that was published. And what we did was we went through all of the joint external evaluation forms and tallied up on an enormous spreadsheet of all of the different indicators and all of their numbers. And then what we did was we created a mean score for each country, so we could compare the individual countries, but then we created a mean sub-Saharan African score for zoonotic diseases, which you can see here, and we compared them to all of the other categories. So you can see we've got prevent, detect, respond, and other here, and these are all of the what are called sub-areas or subcategories. And you can see zoonotic diseases here. So the mean sub-Saharan African score for zoonotic diseases was 2.35, so sort of slap bang in the middle. But actually that puts its ranking out of all of the 19 different categories at number 5. So actually, in terms of how much, I suppose, African countries consider zoonotic diseases, it's quite high up there as a priority. And if you look next to it, antimicrobial resistance is way down there at 17. So it would suggest that zoonotic diseases is more of a focus than antimicrobial resistance at the current time for sub-Saharan Africa. So we've got a map here, and this just shows the mean country scores for all of the countries that were included. So North Africa is in grey. So in terms of sort of health and the WHO sort of regions, North Africa is designated as a separate area. And the countries in black have yet to do a joint external evaluation. You can see that the majority have, which is really, really good. And you can also see that the majority of countries have either limited or developed capacity when it comes to zoonotic disease preparedness. There are a few that have no capacity, so that's somewhere under 2, so it could be 1.5, could be 1. And there are a couple of countries that have either demonstrated or sustainable capacity, which means that actually they could be used as really good examples to other countries that they could take into account and follow. Although, of course, for instance, you can see South Africa is in green. A country like, say, Chad couldn't just look at their score and say, right, we will implement exactly what they have done, because South Africa has certain issues or advantages and Chad will have different ones. So these measures have to be looked at, but also kind of adapted so that they fit every other kind of country. One of the kind of results that we identified, or one of the indicators, was, does a country have a One Health agreed list of 5 priority zoonotic diseases that they want to kind of focus on? So when I say One Health, I mean agreed by the Ministry of Health, the Ministry of Agriculture and Environment, or whatever the equivalent is in each of those countries. And you can see that actually only 43% of countries had this agreed list of 5 diseases. So if a country reported those 5 diseases, we identified it, and we then sort of created this chart. And you can see that actually at the top, all of the main diseases that, as I say, almost 90% of countries had on their priority list is rabies, anthrax, brucellosis, and bovine TB, all of which are neglected diseases or zoonoses, which I think maybe people might find quite surprising. I suspect maybe people would think Ebola would be further up the list, or dengue, yellow fever. But yeah, actually the majority of the countries actually put neglected diseases, which is, I think, quite interesting. So looking at the results as a sort of from a One Health kind of perspective, 70% of countries that we looked at did have veterinary worker training on zoonotic diseases, which was pretty good. So that means that there are either MSc courses, or within the veterinary kind of training, these veterinary workers are actually being exposed to the principles and concepts of zoonoses. So not just, animal diseases and treating animals for their own diseases, but actually considering how those diseases might be spread to humans. 34% of the countries we looked at had an interagency or One Health zoonotic response team in place. A quarter of countries had conversations between the clinical side and the veterinary side when it came to reporting zoonotic disease, either outbreaks or incidences. And 14% had a multi-sectoral or One Health action plan in place, which again, whilst they might not necessarily have an action plan fully in place, it might mean that they are currently kind of planning for it. So just because 14% seems quite low, but it might just mean that there are other countries that, whilst they kind of have something in place, or they have an action plan in place, but for instance, it hasn't been approved by every single ministry that needs to be involved. And what we took away from our report was that whilst zoonoses does seem to be quite high on Africa's sort of collective conscience and priority list, there was definitely a sort of a lack of this One Health approach to it. So involving clinicians and veterinary and environment together, and really sort of cooperating in this really sort of synergistic way. And I think, as I say, our kind of response to that was, we really need to ensure that this is a thing, so that it can be approached from all of the different angles, and we can really identify how best to be prepared for zoonotic diseases, and more importantly, their outbreaks if they occur. So yeah, that's the end of my presentation, and these are all the people that were involved in the paper that we did. So thank you.
Thank you very much, Dr. Elton. So just remind you to put any questions you have in the Q&A box, and so that we can put them to our 2 panelists. I don't see any questions currently, so give everyone a chance to get typing. You can also put your hand up if you want to ask a question live. I think that might be another option, because we've got about 20 minutes or so for questions. But whilst we're waiting for those questions, maybe I could ask a question myself. And it's Dr. Elton, I wanted to ask you about the heat map, for example, that you presented. How confident are you in those areas which were identified as being hotspots for zoonotic infections, that was a true representation, or is there a risk of a lack of data from some areas making them appear low risk?
Yeah, absolutely. So what that study kind of was pulling together, it was kind of a review, and it was pulling together lots of other, studies from all the across the world, trying to identify, right, well, this country has said this is a problem here, or we've identified X amount of mammals that have potential zoonotic transmission. So it was a case of kind of bringing together all of that data, but obviously how robust each individual paper was might have varied, and like you say, surveillance in a lot of places is likely to be incredibly low, and it's probably most lowest in countries where actually these are the biggest kind of problems. So yeah, I think whilst that paper did give kind of probably a good general view, it probably doesn't or isn't able to delve that deep, and this is kind of the real problem with zoonoses, is that we just don't have the surveillance capacity.
So for our One Health students today, focus on the areas which weren't hotspots, because that's where we need more evidence.
I think even in the ones that are hotspots, as I say, this is just what a paper, say, for instance, from, I don't know, Tanzania has said, these rodents have this amount of zoonotic diseases, but they may have missed all sorts of things that, it's, we can only report what we know, and if we are missing things, then it is quite difficult, obviously, or impossible to know exactly what's going on out there. So everywhere needs more surveillance, I think.
Great, thanks, Lindsay. So we have a question now from Anne Alain. I think this is probably a question to Dr. Dar. Is how does WHO or IHR define sustainability of systems?
Yeah, and so thanks for that. That's a really interesting question, and the short answer is they don't. They don't define it, and in a sense that's part of the problem. I think there's a general definition in terms of having the workforce capacity to do something and the financial funding available. So within the IHR context, it's usually is the country using donor funding to support this program or this activity or interventions, or is it doing it itself through its own health system or agricultural or whatever financing and its own national budgets? So that's usually how it's done. But typically, within the UN system, in terms of the Sustainable Development Goals, it's defined across sort of the three parameters: environment, social sustainability, environmental sustainability, and economic sustainability. So those are the three parameters used within the UN system.
Thank you. Another question from Olivia Maskell. And I think this is a question that both of you might wish to comment on, is do you expect antifungal resistance to become a problem in the future? Is that something you might like to comment on first, Dr. Elton?
Sure. I suppose, rather unlike bacteria, fungi either are quite sort of mild, sort of skin based, so like athlete's foot, for instance, which are relatively easy to treat, although there are definitely resistances to that kind of thing. I guess the problem really with fungi is more the systemic diseases. So for instance, if you get it in the lungs, then if you have resistances to the drugs that treat them, then that could be a real sort of even more life or death problem, I guess, than for the sort of external ones. But I think we are seeing, although I don't quite know the figures, we are seeing resistance increase across all of the kind of microbes, so parasites, viruses, fungi, and bacteria. So I would imagine that it would increase in the same way that bacterial problems are, because we just, especially in low and middle income countries, the use of these drugs are not regulated. And so if they're being used sort of inappropriately, then we're going to see more and more resistance, I would have thought.
And Dr. Dar, would you like to comment on whether this is an area perhaps which is neglected, where we have a lack of data, or where other issues have taken prominence? Is this an issue that we are underestimating potentially?
I mean, I think so, and I think that's sort of what I was trying to get at. That a lot of the investment, both in the science and the research that's being done around this, is being driven by a security paradigm. So so we tend to underinvest in areas where we don't see, frankly, a national health security threat emerging from. So yeah, fungi is part of it, but also, you know, fungal disease in the agricultural sector. It's not just that fungi infect humans. There's huge issues with crop production and agricultural production. So, you know, I'm sure, I'm not a biologist or environmental scientist, but I'm sure that's an underinvested in area, needs to be addressed. Yeah.
Thank you. And a question again, I think, to Dr. Elton. Given a lot of African countries fall into the LMIC bracket, how big an issue are zoonoses relative to other developmental challenges that African governments must tackle?
Yeah, so I think I pointed out on that sort of list how high up actually zoonotic diseases were compared to AMR. So zoonotic diseases were sort of 5th on the priority list as a general rule for across sub-Saharan Africa, whereas AMR was way down in 17th place. Sort of vaccinations were very good. A lot of African countries have dealt incredibly well with vaccinating people for various things, but actually AMR has been relatively neglected, because I think AMR is really a problem that's only come to our collective attention relatively recently, whereas actually zoonotic diseases have always played quite a big role in especially African or lower middle income countries, because that's where they tend to kind of emerge. So Ebola is a really good example of that. So I think zoonotic diseases will always be quite a high priority, because they cause or can cause such an incredible burden on a healthcare system. And so as I think we saw with COVID-19, actually, where the high income countries thought we will deal with this much better, actually, it turns out that a lot of African countries dealt with COVID as well, or if not better, because actually they were much better prepared to deal with mass outbreaks of things, because they have training in it, they have experts in sort of emergency response, whereas we, for instance, in the UK, we talk about it and we maybe do training, but we don't have to ever actually deal with it in real life. So I think zoonotic diseases will always be fairly high up on the priority list, especially in low middle income countries, but I think that's a good thing.
Thank you. And Dr. Dar, do you have a comment on how health measures up relative to other developmental challenges? Because Dr. Elton has discussed the different elements of health and relative prioritization, but if, you know, we're all working in health, we're all biased, but you're dealing with governments. How big a priority is it for them?
I suppose human health does do well in comparison to the investments put into ecosystem health or animal health. So certainly there's a big difference in the attention that goes in investment that goes into it, and probably rightly so, but the balance isn't probably optimal. And just to come back to some of what Lindsay is saying, even the way the prioritization is done across the spectrum of, say, zoonotic diseases is very interesting to go into. So if you look at her slide where they prioritized a bunch of diseases, one thing I'd say to Lindsay is, Lindsay, I know you perhaps didn't include the whole slide, but if you look at the whole slide, the highly pathogenic avian flu is probably on that list. And I
Yes,
noted you
yes,
removed
you're
it.
right, it is.
But I noticed you removed it, and the reason is it makes for slightly uncomfortable reading, right? Why would a very low income country like, say, the Central African Republic have as a number one priority highly pathogenic avian flu when they've had no cases of this? It has no no burden to their particular society. It's very difficult to explain from a scientific perspective, apart from if you're saying that our country should be prioritizing things that are that have global pandemic potential. So if you weight your criteria by global pandemic potential, then you'd say yes, HPAI is a high risk pathogen, right? And I think that's part of what happens here. So when these countries have done prioritization exercises, they've used the US CDC One Health One Health prioritization tool, and that gives outweighted weighting to viral infections of pandemic potential. So that's why you don't see like schistosomiasis or nematode ascariasis or things which have a huge burden of disease in Africa appearing on the list. You'll see instead things like HPAI. So even though these countries hardly have any expertise to deal with HPAI or don't have any burden, don't have like an expansive poultry industry, they're still prioritizing HPAI as number one or number two in their lists, and that's what then causes a distortion. So you've got to like almost know the political and funding and all that background to the assessment in order to properly interpret it.
I should also add that on that sort of chart, that was purely what countries actually reported to have on their list. So some countries did report the 5, some countries reported 1 or 2, some countries didn't. They said they had this priority list, but they didn't actually report specifically what was on there. So not only is what they report is obviously what I had to go on, but if they had other things, like you say, avian flu, then yeah, it might be more of a priority or less of a priority, but it's hard to tell based on what you've got to work with the data that you've got, unless of course you are aware of governmental reports and things like that.
And our next question is also relating to the joint expert evaluation. And that's a question from Catherine Swartz. Is the JE process continuing following the visits of the external evaluation teams? What's going to happen afterwards to follow up or continue gains or capacity development that might be needed in this area?
So they're entirely voluntary, but so they started in about 2016. And so some countries have very old ones, but from sort of the original kind of point where they started. But there's nothing to stop a country repeating it sort of 10, 15, 5 years later. So it can be updated if presumably there is a need for, or there's significant improvements in things, I would have thought.
So yeah, I can add a couple of points to that. The joint external evaluation is part of what's called the IHR, International Health Regulations Monitoring and Evaluation Framework. So the JEE is one part of that process. They're supposed to happen once every 4 to 5 years. You also have annual self-assessments, which countries send back into WHO. And the third part of the process is to do simulation exercises and after-action reviews. So whenever you do have an outbreak or health security issue, you're supposed to do an after-action review, and that forms part of that cycle of upgrading and improving your capacities. There's also another thing called the IHR Benchmarking Tool, which is meant to allow you to better categorize what capacity you're at. So when you're scoring yourself 1, 2, 3, 4, 5, you're supposed to have a set of criteria for doing that, and that is present in that sort of benchmarking tool. A lot of these things are now being revised in light of COVID-19, because COVID-19 has shown that you need to look at wider parameters across society if you want to be able to prevent, prepare for, and respond to a pandemic or an outbreak of sort of national, almost existential proportions. The JE process looked very much at issues within the health sector, and to some extent extending to animal health and livestock systems, but it didn't look at other issues like the social contract between the population and the government, or all these other issues, the stability of the rest of the health system to be able to respond, or social protections or things like that. So those are now being thought of and integrated And there's going to be a new process launched, which is called the UHPR, the Universal Health Preparedness Review. I think that's what it stands for, where countries are negotiating how they do future peer review of systems and capacities to prevent and respond to pandemic threats.
I should also add that the OIE have their own kind of a veterinary version of this as well, which kind of overlaps in some aspects, especially obviously with zoonotic disease. But yeah, they also have one too. The
PVS, that's the Performance of Veterinary Service.
So I have two more questions, and I think we have time to take both of them before we wrap up. And the first question for you, Dr. Dar, I think is, why is there a lack of AMR surveillance in the environment? So thinking now about the environmental dimension, and why would investigating this gap in research help control AMR risk? Is that something you could comment on?
Yeah, I can. I suppose again, I'd argue that that because the whole issue has been driven by, in a sense, us seeing increasing rates of resistance in tertiary care hospital settings in the West. That's been a focus for a lot of the surveillance investment, that and the use of antimicrobials. So on the stewardship side, over-the-counter sales, for example, and consumption in low and middle-income countries and across the world. So volume of sales and surveillance of specific indicator pathogens within hospital settings has broadly been what the focus of investment has been on. And yeah, as a result of that, other bits of the pie, in a sense, get underinvested, and that includes the environmental sector. So I would argue, and perhaps that's me being slightly cynical, because we have better control systems in terms of effluent and sewage, agricultural runoff, and sewage disposal in Western settings, we tend not to worry so much about environmental contamination because those are monitored through different systems. Whereas in low and middle income country settings, that's perhaps more of an issue, and perhaps we should be doing more, certainly sentinel surveillance of areas where we would think you would find, higher numbers of higher proportions of resistant pathogens. So things like sewage effluent, things like agricultural runoff. I mean, there's already been a lot of association in that space. So a lot of the hotspot areas where you've had extreme drug-resistant typhoid infections in Pakistan, for instance, have been almost geographically co-located, where they've had the sanitation lines mixing with the water lines in peri-urban and slum settings. Because those pipelines are so old, there's a lot of mixing between the supposedly clean water pipes and the sanitation pipes, and you see these continuing outbreaks of gastrointestinal and resistant infections in those settings. So it's important that we do start investing more in the environmental surveillance piece.
Thank you very much. And my final question, I think, is a perfect one to end on, and I'll ask each of you to comment in turn, starting with you, Dr. Elton. The question is, do you have any advice for students who are looking to make a career in One Health?
I guess you have to think outside your box, I suppose. I mean, doing a course like a One Health course is a good place to start, but a lot of us will have a career, or that you start in one specific thing. So I did biology, so I suppose it was relatively broad, but I went on to do medical parasitology, and then I did a PhD on plague, and so I became quite clinical. But actually being part of Pandora makes you, it kind of has opened my eyes to the fact that we aren't sort of alone on the planet. We do need to think about things in a much broader way. And so I suppose being part of those conversations is really helpful to kind of broaden your perspectives on these kind of things in a sort of, I suppose, a scientific sense. So things like social media are really sort of good ways. Twitter especially is a really good way to identify sort of these conversations that are happening. We've got the Pandora Network has a global health network hub, where we've got sort of, so we've made a page on how to build a One Health research project. And so all of the questions that you sort of might need to ask yourself when you're building up a project, you know, what to consider, who to involve, because obviously you might be an expert in one thing, but you can't be an expert in everything. So you need to sort of bring in people from all of the different aspects to really build a proper, true One Health kind of research project and a career.
Thank you very much. And Dr. Dar, from your perspective, what advice would you have for future One Health careers?
Well, I'd echo some of what Lindsay's saying, but you know, you can approach it in one of two ways. You can be a sort of jack of all trades and try and understand and really broaden your understanding of One Health issues across the three sectors, and try and develop yourself in a way that you're sensitive to developments in all three sectors and understand how they're applied, applied across different disciplines. You can do that, or you can choose to specialize in one sector, but still be sensitive to, you know, how those be an expert in your own right, and that perhaps gives you the added advantage that, you know, you're still always employable. There's something you can fall back on, a position to fall back on, because at the end of the day, you've got to eat, right? So you need to be employable. So do think about that, but that you think more broadly about how your expertise or your technical specialty can be applied in other sectors and in other settings, and you know, you really approach all your work in that way. And the other thing is, I'd say, is that, you know, I put up those sort of 5 principles or values of One Health, and I think it's really important that we embed that in all our thinking. The equity part of it, the you know, the socio-political parity, the stewardship, the transdisciplinarity, the sort of socio-ecological holism, that is all really important, and that we put that at the heart of whatever it is we do, that we're interdependent with other animal species and with our ecosystems, and that we appreciate them and ascribe a value to them independent of the value we ascribe to ourselves as humans. That's really it.
Thank you both very much. I think it's been a very thought-provoking and enlightening discussion this afternoon. And I see that Lindsay's popped up a link to Pandora in the chat, so you can find out a little bit more about that. But I'd just like to conclude by thanking our 2 panelists from this afternoon, and then handing over to Sharon for some final words. But first of all, some thanks.
Indeed. Thank you very much. I actually don't have very much to add other than grateful thanks, because one of the perks of doing this job is that I get to learn so much about the world we live in. And I think that's the big joy for me of working in LIDC as a non-academic and a non-scientist, non-researcher, is that I have to learn about the messages that we want to communicate to people. And this is certainly a huge challenge. I mentioned before the webinar started that I'm half Sierra Leonean and half Lebanese, so these issues are really of direct consequence to my actual family and to the majority of people in this world. So I want to learn more, and I'm grateful to be in a job that enables me to do that, and that we get other people as well able to have this time with you, because it is really a privilege. We're very grateful that we've had the MSc students with us today. Thank you all very much for joining with us. Please remember to save the links from the chat. Join LIDC. This event is being recorded, and we will share the recording soon. But thank you, Dr. Elton and Dr. Dar. Your presentations were very accessible, and they met the reasons why we need to be active on this issue are now very clear, beyond any doubt at all. Professor Clarke, I look forward to hearing your dulcet tones come out of my television set and radio more often. Thank you for the work that you're doing against malaria, and I look forward to a safer world once the MSc students have graduated. Thank you for taking your time to join us, and goodbye for now. Bye-bye.
Okay.
Thank you, everyone.
Thank
Bye.
you.
Bye, everyone.
Thanks. Bye.
Thanks, and bye.